Hi, everybody. My name is Sarah Wilson. Today, I'm going to talk to you about bipolar disorder and well-being and how we can make sustainable changes to well-being in bipolar patients. This is a subject that's pretty near and dear to my heart. My family has a large history of bipolar disorder. I myself was diagnosed with bipolar disorder earlier this year. I was diagnosed with bipolar too, so my form of bipolar is not quite as severe as some of my family members, but it's still something that's very important to me. So we're just going to kind of jump right in here. I'm not going to go through these in great detail because I think that we've all had abnormal psych. The only one that I really want to cover is the circadian rhythm. This is the 24-hour cycle that kind of tells our bodies when to wake up, when to sleep, and when to eat. Um, People who have bipolar disorder can have very disturbed circadian rhythms. So I had a pretty nasty depressive episode about this time last year, and I slept for 32 hours. So it can really kind of disturb that cycle. And when that cycle is disturbed, it really disturbs our psychological processes. The rest of these terms, I think we all know, and I'm not going to cover them, but you're more than welcome to stop the presentation and look at them in greater detail if you want to. So bipolar is split into two different forms. So first we have bipolar 1 disorder. This is characterized by manic episodes that last a minimum of 7 days, or by manic episodes that are so debilitating that a person needs to be immediately hospitalized or placed into psychiatric care. Um, Something that can happen in bipolar 1 patients is hallucinations and delusions. And sometimes for people that don't have a very good understanding of psychology, they may confuse this with schizophrenia because that happens in schizophrenia as well. However, these are not one and the same. Bipolar 2 disorder has hypomanic episodes, which are not quite as severe. They're not quite as debilitating. Both of these types of the disorder have depressive episodes intermixed with the manias or the hypomanias. So there are other factors, there are other things that can play into bipolar disorder. We're not going to cover those just for time's sake, but just know that this is not a comprehensive list. I'm going to leave these up for about 5 seconds. This is just a diagnostic criteria. I think we've all had the abnormal psych and we know what this criteria is. We've seen it before. So we're just going to kind of move through these pretty quickly. This is just a continuation of the previous slide, so we'll just leave it up here for just a second. This is just a diagnostic criteria for actual bipolar disorder, bipolar 1 and bipolar 2. Bipolar disorder can be a very hard disorder to live with. And I'm not going to cover all of these, but I'm going to cover a couple of them pretty quickly. It can be a really difficult disorder to live with because of how it manifests itself. So the first thing that I want to cover is the increased sexual risk. This is important because bipolar patients feel like they're invincible, especially when they're in manias, and so they can have multiple partners and not use protection. And this leads to increased risk of HIV and other STIs that can really be debilitating or life-ending. And not only that, but they can pass it on to a lot of people before they realize that they even have it. Another issue is increased recreational drug use to self-medicate. So my grandfather was diagnosed actually schizophrenic and what we now believe is bipolar. He was diagnosed schizophrenic and he used alcohol to self-medicate because in the 1950s and early 60s, they didn't have a lot of medications that can control his symptoms. Individuals who do go and undergo treatment oftentimes will take their medication until their symptoms are controlled, and then they stop taking it because they feel better. What they fail to realize is that it's actually the medication that's making them feel better. So it just kind of leads to this really bad cycle of being on a medication and being off of it. And this leads to more occurrences of hypo or manias and depression. And it can also lead to rapid cycling, which can be a really, really difficult thing to deal with. So the only thing that I really want to cover on this slide is ECT. ECT kind of fell out of favor after the 1960s because it can have really bad impacts on people's nervous systems. So my grandfather, for instance, underwent ECT pretty severely for a long time, and it destroyed his ability to control the shaking in his hands and legs. He committed suicide in 1968, and what they discovered was that when he was in the process of committing suicide, he actually had to prop his hand up on a pillow to control the shaking so that he could pull the trigger. And that is just a very sad way to die, to know that you can't control your body. Something that was supposed to help you has destroyed your body even more. Now, in current times, they don't use ECT in the same way. It's not used as severely. It's not used as often. It's mainly used to help people who have severe manias and people who don't respond well to medications. I want to quickly point out the bottom here where it says genetic testing. I underwent genetic testing, and this was a lifesaver for me. Medications are often used on a trial and error basis, and what we find is that people have side effects with medications that don't outweigh the benefits. And so I was able to do genetic testing, and I found a medication right off the bat that worked for me, and I still take the same medication that I started on. And that can really increase people's well-being. When you're going through the process of finding a medication, it can be really disheartening to keep going through medications that aren't working. And that can have a real impact on people's well-being. So here we're going to actually start covering some of the research that I did on how to sustainably change well-being for patients. This first study looked at the idea that more episodes of depression and mania have longer lasting impacts on well-being and quality of living and functioning in patients. And so what they found is that it's not actually the manias that have long-lasting impacts, it's the depression. And it's the first few episodes of depression that have the most impact. The impact comes from pretty permanent biochemical changes in the brain from these depressive episodes. And that has some pretty significant impacts. So what we found is that to increase well-being in patients, we really need to be able to diagnose and treat them early, and we need to treat them aggressively. And this is going to help slow down the progression of the disorder, and it's going to increase well-being over a longer lasting period of time. Another thing to keep in mind here is something that I kind of covered earlier. Manias fall off. They become less and less and less as the disorder progresses, and depression kind of takes over, and it's far more common to have depression later, and so it kind of perpetuates those biochemical changes and the permanence of them. So I actually found two different articles that I wanted to use that included social support. I think social support for bipolar patients is incredibly important. When you feel isolated and you feel like you're alone, why should you want to feel better? So this first article specifically looked at the impact of social support from family, friends, and partners, and the impact that those people had on recovery of mood symptoms. And what they found is that people who have bipolar disorder kind of isolate themselves, so they come out of contact with friends and family members when they're having mood symptoms. And that can have a really detrimental effect on recovery. So people who had contact with their family members during times of mania or hypomania had stronger recovery scores. And people who had more social contact, and I think it's really important here to note that it had to be contact with more than one friend, so 2 or more friends. So people who had more social contact with 2 or more friends during mood symptoms had higher recovery scores than those who had little to no contact with other people. They also found that participants who lived with a romantic partner did not have a higher recovery score. And this kind of leads to the assumption that it may be the quality of the relationships that increase recovery scores and maybe not necessarily the quantitative amount of relationships. And this kind of flows into our next slide. Here, Boyers and Rowe wanted to look at the impacts of social support on bipolar patients and their partners, and that is critical. So what they found is that a lot of times bipolar patients have more social support than their partners, and this can lead to a really negative impact on the relationship as a whole. And a lot of times when that happens, relationships kind of fall apart. Um, so what they found is that emotional social support is positively associated with relationship satisfaction from both partners. It's important to remember that you need to have a social outlet. You need to have somebody that you can talk to about things that are happening in your relationship. If you're a partner to someone that has bipolar disorder, it can be very hard to live with them. They can be hard people to rationalize with. They can be hard people to live with. It's important to have somebody outside of your relationship that you can talk to. Um, So this study was something that was really interesting to me, and it actually covered something that I have never heard of before. So this study talked about mindfulness-based cognitive therapy, and what mindfulness-based cognitive therapy does is two things. It increases awareness of thought patterns, and it reduces reactivity to these patterns. And this kind of prevents a negative spiral of thinking and feeling. And the focus is to change your relationship to these thoughts and your feelings and your bodily sensations, um, but not so much changing the content of them. So by doing this, you're shifting your perspective and observing your experience in a different way. And it kind of allows you to stand back and realize that these are just thoughts in your mind and you don't necessarily have to engage in them. And so this kind of leads into rumination. So this particular study found that bipolar patients have a tendency to ruminate, and they ruminate in depressive episodes and they ruminate in manic episodes. And so they're just kind of self-perpetuating those episodes and drawing them out longer than necessarily they need to be. Um, and so what they found is that mindfulness-based cognitive therapy actually helps to stop that ruminative process. And it increases mindfulness, emotional regulation, psychological well-being, positive affect, and psychosocial functioning. And it reduces the residual mood symptoms. So what they found is that 3 months later, all of these increases were maintained. And that can be pretty significant for someone who has bipolar disorder. So now we kind of need to look at how all of this is synthesized to what we've already learned this semester. So we know that bipolar disorder can be a highly stressful disorder to live with. Um, Cohen, Deverts, and Miller discuss the fact that psychological stress can have impacts on disease, and they discuss the past research that shows regulation of the immune and inflammatory processes that have potential to influence depression. So for bipolar patients, the shifts between mania and depression can be highly stressful experiences, which can linger into non-symptomatic times. And it's not uncommon for patients with this disorder to not comply with their medical regimens. So this noncompliance allows the disorder to progress in ways that also increases stress. And unfortunately, the biochemical changes that happen in the brain during depression um, have permanent effects on quality of living and psychological well-being. So if we can control the psychological stress bipolar patients experience by increasing medication compliance, we can kind of lessen the permanent impact of biochemical changes and the inflammatory responses that come with depression. DeLongis, Folkman, and Lazarus looked at the impact of daily hassles and perceived social support on psychological and mood symptoms, or physical and mood symptoms, I'm sorry. They found that our perceived social support does not have an impact on how we feel physically and psychologically during times of great stress. And what makes the impact is that we feel we have a lot of emotional support from people who are truly important to us. And for bipolar patients, this is the same. They need a large amount of social support to deal with the stresses that come with mania and depression, and their partners need it as well. So we also covered a chapter of a book by Hupp, Rittman, and Jewell, and it discussed several different forms of CBT that can be beneficial to individuals with a variety of mental disorders. Cognitive restructuring can be highly effective for bipolar patients because it helps them to change maladaptive thought processes that can be brought on by depression and mania. And it helps to change these processes into adaptive thought processes. Um, MBCT is a modified version of cognitive therapy, and it also helps to change negative thought patterns, but it does through meditation and breathing exercises. And it kind of helps to stop the thought processes before they even start. And both of these types of um, cognitive and behavior therapy help kind of reduce the relapse rate of BPD, and it also helps slow the disorder progression. So lastly here, I just want to say that bipolar disorder does not have to be a hopeless disorder. It can be a very difficult disorder to live with, and it does affect well-being in ways that many other people without this disorder will never have to face. For me, I've had family members that have died from suicide because of bipolar disorder. I've had family members that have died from drug and alcohol use. And that can make things seem pretty hopeless when you're facing the same disorder. But there are ways to increase well-being for patients and their families. It may be more work, and they may have to put more effort into it, but it's not impossible. And the rewards that come from the work that they put in are far worth it in the end. I hope that you all take something away from this. I hope that I've educated you in some way. If you have any questions, please feel free to reach out to me. I'll be more than happy to answer anything in any way that I can.